Are we ready to get started?
Sure, go ahead.
All right, excellent. Well, good afternoon, everybody. Thank you for joining the first ABD Society signature event for 2020. I know it's a little more delayed relative to what it has been in the past. It's been an interesting year, to say the least. For those of you I don't know, my name is John Thomas, and I'm the president of the ABD Society. For those of you who are joining us for the first time today, the Analytics and Big Data Society is a nonprofit organization based in Charlotte that believes in the use of data for social good. Our mission is to establish the Society and Charlotte as a national analytics and big data hub. Throughout the years, we've been carrying this message through various events that we host, such as our monthly data analytics speaker series in partnership with the UNCC School of Data Science, the signature events like the one that you're at right now, as well as our largest and biggest annual event, the Queen City Hackathon. For today's discussion, we're going to be running a series of questions as we go along, and I'd encourage each of you to participate in them as they come up. I'd like to welcome today our great panel of experts. Before we go ahead and meet them, I'd like to introduce our moderator from today, that's Carl Hightower. Since 2018, Carl has worked with leaders from across the Novant Health System to provide the digital products and services required to deliver remarkable care to the patients and communities that we serve. Carl has held executive roles in large retail and energy trading companies and has held pivotal roles in telecommunications, manufacturing, supply chain, insurance, government, banking and finance, and food and beverage. In these roles, Carl set the strategic direction and created alignment to direct structures during the pivot years of these industries, devised and led game-changing initiatives, increased revenue, became an early champion and expert in cloud adoption, personalization through social media data, real-time pricing structures, and extreme automation through machine learning and AI-based algorithms. Carl, I'll turn it over to you.
Thank you, JT. We're really excited to be here. We have four fantastic panelists today as we start to talk about remote patient monitoring and what it means to the future of healthcare and how we move things forward. So I will let them introduce themselves. I'll start full Brady Bunch style here as I see it. So Anna Gupta, can you please tell us a little bit about yourself?
Hey, Carl, thanks, and good afternoon, everybody. It's a pleasure to join this panel. I'm very, very impressed with the panelists as well as our moderator, Carl. I myself have been a Wall Street analyst for over a dozen years, but bookended my career with consulting, management consulting, and corporate roles, including most recently a C-suite role as Chief Strategy and Innovation Officer at Florida Blue Cross Blue Shield and its parent GuideWell. In Wall Street, which I did cover from 2007 through 2019, I covered the payers, the providers, and the digital health industry. And prior to that, I was at Aetna in the corporate planning team supporting the C-suite. I headed up drug development strategy at Pfizer, so I have a pretty strong grasp on the therapeutic side, and I was at McKinsey.
Thank you, Anna. Next, Sasha Cahill, can you tell us a little bit about yourself? Sasha, you're on mute, so would love to hear your voice.
Sorry about that. Hi, everyone from Switzerland. My name is Sasha Cahill. I am a serial technology healthcare entrepreneur. I have built and brought to market solutions for payer, provider, pharma, self-insured medical device, and patients. I'm passionate about implementation of AI, ML, and IT in the healthcare space and improving outcomes and decreasing the cost of care overall. My recent company that we started during COVID, March of this year, we rolled it out, is a remote patient management platform for cardiology, adults, and pediatrics. The name of it is PX Pulse. Thank you, delighted to be here.
Glad to have you. Lisa Crimes, go ahead. Could you please introduce yourself?
Sure. Hi. Thanks. Thanks, Carl. Thanks. Great to
to be on this panel and to join everybody this afternoon. My background is primarily in product management and strategy across health IT. So that's been in a number of different focus areas, starting with the provider world. And as I saw the opportunities for the provider-payer collaboration, I shifted over to the payer side. Most recently, over the last several years, being Chief Experience Officer and help building out some data and strategy opportunities there. So currently Chief Marketing Officer for Preventric, which is a digital health solution. Happy to be with you guys this afternoon.
Great to have you. Shika, can you please let the people know who you are?
Hi, everyone. Happy to be part of this panel. I am the Chief Technology Officer at Syntelli Solutions and primarily responsible for the solution architect and the technology for our clients, which base multiple industries, including healthcare. Apart from that, I'm very much involved with ABD Society in data for social good and the wonderful hackathons that these guys do to help the community. And then I also co-chair a local chapter for SIM Women in Charlotte. Happy to be here.
Great to have you all. Sasha, can you tell me what remote patient monitoring means to healthcare and also kind of how it's going to be vital going forward?
It's a good question as the start of this conversation. I think before I answer it, I would like to level with our listeners on what RPM versus telehealth is. So essentially remote patient management or monitoring, or RPM, is a method of healthcare delivery that includes the latest advances in healthcare IT, and it allows to gather patient data outside of a traditional healthcare setting, which includes consumer-grade and medical-grade devices and wearables, where telehealth is a much broader term, and it includes video, chat, call, VR, and other methods to gather patient data, and that, of course, includes RPM. Now, in order for me to answer these questions, because I think we all have probably our own perspective, I'd like to outline benefits that I see for providers and for patients of using RPM. For providers, I would say, of course, it allows data access. It's a continuous data access, 24/7 or 365 if needed, depending on the patient's disease. Of course, during COVID, we found all in other significance in RPM that allowed to protect the health of healthcare staff as well as non-COVID sick patients. Also, for healthcare providers, it allows to improve patient experience, also allows to decrease burnout, some argue, and of course, decrease long-term healthcare costs while improving the outcomes. And there are some early day studies that show that RPM allows revenue generation and patient retention and acquisition. As far as for patients, I would say, of course, access to care. Also, of course, during COVID, we once again were reminded that there are a number of groups of patients that have been affected by COVID a lot more than others. And with the spread of RPM and telemedicine tools, we can, of course, fix that gap in care delivery. And of course, it gives an opportunity for patients to interact with their caregivers 24/7 or 365 as needed. And for providers, it might be access to patient data in real time, but for patients, it's an opportunity to get help from care provider, whatever they are. It could be at their home, it could be while they're shopping or something else, if God forbid an urgent situation happened.
Anna, how is this going to end up affecting the business side of healthcare from a patient perspective?
Yeah, so I think of it in terms, Carl, of the various use cases, if you will, that are out there, and those that benefit the most, but also overcome the barriers to adoption. In fact, align the incentives across patients, providers and the payers. So the big one, of course, we've talked about COVID, and I don't think while many of us ever had anticipated a pandemic in accelerating adoption, is it's clearly one that both all the three constituents care about. But the couple others that I think are perhaps somewhat less celebrated, if you will. The first would be just aging in place. The notion that we have America's aging population with the baby boomers wanting to be more at home and then taking care of, with chronic disease management. There is an incentive for the patient. There is an incentive for the payers, clearly, both government and commercial private payers, but also providers because they're taking on shared risk. And I think that's a critical aspect of the adoption of telemedicine and remote patient monitoring along with it, for cardiology, for metabolic disease, diabetes, hypertension, mental health, and so on. So that's kind of one big one. The size of the market for telemedicine, and RPM is integrated with that, which was estimated at like 40 to 50 billion different ranges in 2018, 2019. And predicted to be somewhere under 100 billion by 2026. Now the estimates for market size have gone well above 200 billion, and the cumulative annual growth rate is tremendously higher. So it's not just COVID, but it's accelerating broader adoption. And then on the provider side, you clearly have rural shortages, clinical staffing shortages, which has been an aspect of this, and bed efficiency. And while COVID in some ways might perhaps slow this down depending upon whether pent-up demand picks up next year or so on. Home hospital and remote patient monitoring had started to really pick up steam earlier this year, before COVID, and pilots had been, by academic medical centers in partnership with payers. So I think all of these are, potential use cases for it.
So with telehealth and virtual health having been slow until the pandemic, how do you see RPM fitting in with that? Because you mentioned, you mentioned remote patient monitoring, home health, hospital, all of these things that fit together. Can anyone kind of give me a piece of the puzzle and how this is all going to work as it goes to now an accelerated pace from where it was very slow adoption before? Lisa, Shika, do you see anything from a slower pace or a faster pace as we move forward?
I'll jump in. Where my mind immediately goes is around data and analytics, but let me say first that I think it's going to continue to accelerate. That's probably the most exciting part of this year for us, is that all those barriers existed, all the financial incentives did not exist to really support the continued adoption. We knew digital health was still going forward, but this accelerated things by, some people are guessing 3 to 4 years. So I think it will continue at a faster pace. There's no going back at this point. That's probably my favorite thing to say this year, is that there's no going back in many areas of our lives, but specifically in healthcare. From a consumer standpoint, just the ease of it, but then the necessity of it when it comes to preventative and basic care that's still very necessary. We see that there's another way to deliver that. Then I said when I started this that my mind goes to data and analytics, because I think that's where we also start to see and understand the value of the data that we're collecting, and the value of then aggregating all of that across all of the multiple sources, and what that does from a predictive, from a predictive modeling and preventing unnecessary problems later on, it really improving overall patient care and outcomes is what are going to be some of the major benefits there too.
Shika, how do you see AI playing into this as you look at the different things within the machine learning and all the different remote patient monitoring? How do you see AI playing a broader spectrum around integrating into that total patient care.
Absolutely. And before I answer about the AI or machine learning, I think Lisa also touched about it. The overall industry, I think COVID did, as a joke, did bring in the digital transformation, much needed digital transformation, and RPM is being part of it. With that social distancing requirement and not to be able to manage the patient and ability to have the flow of the data on a continuum basis in the hands of clinicians and the care providers, as well as the patient. That's where the bigger value is also coming in. And all our AI and machine learning systems, initially it was all about, oh, how can I reduce the readmissions? How can I figure out who are the patients who are at higher risk? How can I move towards the value-based care with the population health use cases? I guess with COVID, with the continuous flow of data that is coming in, the predictive analytics and the ability to manage your vitals has been tremendous. And as we are learning more and more about this disease, AI and machine learning again is being utilized to come up with those patterns to be able to figure out who are the patients at higher risk. If there is an event that can happen, if your heart rates and your SpO2, everything that is being mashed together, and lots of data that is coming in. So it's really helping out the providers and the patients to get the value.
So Sasha, what do you think are some of the biggest barriers going forward for adoption of RPM? So what are your thoughts on this actually getting over the hump, becoming just a part of our daily lives?
I think they're probably the same, Carl. I think that uncertainty around reimbursement, we have to talk about that. So as much as providers want to deliver care, but they've got to be reimbursed for their time and effort. Of course, we still have questions around clinical appropriateness. And then you have still some, I would say, lack of physicians buy-in and lack of support from leadership perspective. And then since you have, it's a care, RPM is a type of care that sort of has to be prescribed. So with lack of buy-in overall from care providers, then patients are not quite aware about all of their RPM options. They've just become aware what telemedicine is, a lot of them are. And just with that being said, just kind of like playing on the answers of Shika and Lisa, I think what COVID has done is COVID has highlighted the need to standardize data. And the fact that in the healthcare space, we have a number of data sources, interoperability is something we still talk about at the conferences. I think the desire to deliver care in the remote setting to be protected from COVID, whether the staff or patient, just highlighted those issues. And I think data standardization, data interoperability also has some effect to why RPMs are not as widely, available for all of the patients in the United States and outside of US, if that makes sense.
Lisa, any thoughts on those barriers?
Yeah,
that was kind of the list of the gambit in there. So don't know if you have more specific things that you think will kind of have to be knocked out quickly.
Yeah, I think most of it was covered. That overall consumer experience or the member or consumer journey is going to continue to be important as we understand, the concept of the digital front door and what that means, and what from a consumer perspective, what this new world looks like and how they navigate it. We have to take into consideration their experience and and expectations. So I think that is so maybe not necessarily a barrier, but still an area that we need to stay focused on and pay attention to. And then completely agree around the interoperability. You know, progress has been made in that area. We're seeing regulatory changes that are occurring that they're getting us a little further along with interoperability. But you know, that need for having access to the data from multiple different sources, pulling that together, aggregating it is what is really going to be the most beneficial. So that I think is definitely an area that we're gonna continue to need to work on.
So Lisa, you mentioned all the data and the interoperability. Shika, how do we distinguish value from noise? As we look at all of the data that comes in, how do we not create hypochondriacs? And how do we get to something that's more meaningful from a technology perspective?
I wish I can have a simple answer like that, that if I'm able to identify really the noise versus the data, but the data quality definitely brings in a lot of value in it, right? And the more data that comes in, the patterns will emerge, and it will definitely, as we move them through the machine learning models, we will be able to segregate out the noise that is inherent part of the data. The key elements will automatically, they do come up. And in terms of interoperability, ability for me to enhance my data, ability for me to mash up my data with the other external systems, not only what RPM is pushing to me in the central platform, but an ability for me to get the external data sets or from other divisions, I guess, brings in the value for my use cases and providing the personalized care for my patients.
If you don't mind, Carl, I would like to add, because what Shika just said is incredibly important. I think there have been a lot of models that have been designed based on EMR data and some of the historic data. The fact that RPM now is a little bit more widespread, you know, was the need that, you know, happened during COVID. It gives us an ability to understand patient outside of, you know, healthcare walls, so to speak. And it gives an opportunity to consolidate the data that we already had with this new data sets, which I would argue, of course, in AI and ML space, right? So that will allow us to build models that are a lot more precise long-term, give us an opportunity to understand patients' health and the impact of their demographics and surroundings and their education and so on and so forth. And I think this is something really important. Now, there's just conversationally, not to deviate too much, but as we talk about all the positives, I think it's important to discuss one challenge that I personally have noticed, and I don't know if any of you as well. So cybersecurity, it seems like during COVID, it became even more of an issue. I mean, we've always had it in the healthcare space, more so in any other industry. But with RPM wide adoption nowadays, I think that became even more of an issue. I think this is something that, you know, it's time for us to talk about, as we are looking to consolidate data from multiple, you know, medical devices, let's say, and consumer grade devices. I think it's important to mention that we need to follow up with some regulatory changes, really.
If I may add on to Sasha, security of the data and all the technology principles that we talk about, right? The compliance, who has access to your data, is it secure? All those things have become even more important because we are living in a digital world where everything is connected, and slowly healthcare is now adopting it, whether it is in a form of an RPM or my IoT wearables using Apple Watches and other things. So just wanted to bring that up.
I couldn't agree more.
So as we talk about all of the things that are coming in and we look at the benefits of this, how does the economic model around adopting this or using or leveraging this start to change? Anna, with your background, what's the advantage from an economics perspective, both for payers, providers, but also the patients themselves?
The patients are looking for clinical advantages with the, you know, safety profile, I think, that is acceptable to them just as much as, they're looking to the clinician to give them that assurance as well, and then some level of convenience to it. But back to your question just around economics, a number of things happened even before COVID, and they were catalyzed, I think, by the government, really. And I think, it would be remiss if we did not say Medicare Advantage and CMS have been certainly champions of trying to foster the adoption of telemedicine, with remote patient monitoring being part of that, because it is part of the data collection, that it's not just claims data, but it's also clinical encounter data, and it is the patient monitoring data. Initially, MA, they just, early last year, they introduced a very small per month per member reimbursement for telemedicine. I think it's not by any means, going all the way, but it was a start in that direction. And just even more broadly, the fact that when you think about a model like Medicare Advantage, the physicians, the primary care physicians, frequently go either at significant risk and even are completely, in a capitated model. So they take the plan will skim off maybe 10 to 15% for their selling, general, and administrative cost, and then hand over the clinical, 80 to 85% of the reimbursement to that physician. So they are heavily incented, as Shrika said, in a population-based model to drive the adoption of a virtual health model that facilitates convenience and member satisfaction for the patient as well, and incorporate that remote patient monitoring data. So I think that is likely to be, in addition to the lasting impact of COVID, it's the MA model that will really, really push the needle forward. CMS has now, I think, along with Trump, with an executive order that was, I think, in partnership with, Seema Verma and the administration, has said that some of the temporary provisions around telemedicine during COVID should be made permanent. I think private payers are trying to push that. Humana, with their big focus on home health, United with house calls. So there's going to be a combined public-private partnership model that'll drive that adoption. The final point I'd make is, it would be, again, remiss of us not to talk about this huge deal that happened between Teladoc, which is the largest kind of virtual health provider that's publicly traded now, with Livongo for $18.5 billion. And you'll see a lot more consolidation between virtual health companies and RPM companies that should continue to drive adoption, because any virtual health company that brings an RPM company under its fold is going to propel that adoption with patients and with providers, and the payers will be part of that.
Lisa, any thoughts on kind of that adoption model? Who's going to be the one that triggers this the most? We have a lot of people like big tech. You have Apple Watch, the latest version of the Apple Watch that's sitting out there that's going to have the ability to read, your glucose levels through the watch band. And you have all of the different tech that's sitting there waiting. Who's going to continue to push, you think, as it gets more and more advanced?
Well, what I think is interesting is you have to think about that from, who are the innovators from a technology perspective, and then who are the innovators from a healthcare perspective, and where those pieces start to cross over. So I immediately, I typically think Amazon and Walmart are the ones who have the consumer angle, right? Amazon from a digital perspective, Walmart understanding that, but they're also large employers, so they are understanding the cost of healthcare. And so from an Amazon perspective, of course, that's why Haven and so the whole Amazon, JP Morgan, Berkshire Hathaway model came about, thinking of those overall costs and managing population from an employer perspective. So the risk model that Anna talked about as well. So, I think some of the small companies are not ones to miss. There's still, that's where innovation often happens, as at a smaller level. But again, I think what we just heard too is another really important piece is as that consolidation continues, think about the best partners through that process. Is it, who are the best ones to come together and that fit well together? Because there will continue to be a lot of noise, a lot of people making promises of, oh, this is the solution that's going to help solve this problem or this problem. And so now as a provider, how do you understand, what decision do you make and which ones do you select? So I think that really supports, again, the comments of consolidation, but looking for those right strategic either partners or M&A activity to pull those together.
Sasha, as a small innovator, I was waiting for you to kind of pipe up on this one.
Yeah, thank you. I was about to add. So it's really, it's interesting what Lisa just said. I would say it's a traditional approach in the healthcare space. So you're a healthcare insider and you create a new solution or make an old solution run a little bit better. So I am an entrepreneur. So 10 years ago, I was an outsider. I was an entrepreneur. I was successful in other industries and brought a different perspective to a healthcare space. And what I have noticed during COVID, and I have to kind of give a broader perspective. So I mentor and speak at United Nations AI for Good, Health Tech Women, also a couple of Heat Lab and a couple of global organizations, and was part of MIT hackathon as well. So what was interesting to me is during COVID, I saw a lot of patients without clinical background coming in forward with solutions that would impact their personal health. And so I think it's a trend. I think it's a trend where essentially COVID gave a voice to a lot of patients because all of a sudden healthcare insiders are now listening to those voices. I have myself mentored several startups where this is their first startup, and in some instances it's a serial entrepreneur. They just never had a healthcare interest, so to say. So I think it is, of course, traditional route. The big players, the employers, of course, they have as skin in the game because their revenue, of course, depends on that, their bottom line. But it's also, now I see patients. I think they're finally taking matters in their own health and trying to impact the way they want to receive care.
Well, it almost is like you're answering one of the Q&A questions that came in from Neil Cool, and he's essentially asking, do you think that this is going to shift with RPM and other things out there? Is this going to shift some of that responsibility of care to the actual patient themselves, as opposed to putting all of the pressure on providers to do every little thing for them? So that's one of the big questions out there. So I'll open that back up. Shika, you look like you're ready to pounce on this one.
Yeah, I guess, isn't the consumer changing everywhere? We look at retail, we look at, like, as a consumer, I have this big smartphone in my hand and I want my data, and that includes my healthcare data. And that care will definitely change. I definitely want to see what my vitals are, what kind of care am I getting, and I think the consumer themselves are much more educated these days. And I think I read somewhere, especially with COVID, the compliance for RPM is much, much higher because people want to get well and they are doing everything, whether it is in a form of an app to put in their symptoms, or is it really a sensor which is transmitting the data. So overall, the consumer behavior themselves is changing, and they are going to be responsible for their data and also the interoperability stuff that comes along with it as well.
How willing do you think people are to share their data? So we have a lot of articles on machine learning and all the things with all of the data that's out there in your health, and everyone gets a little freaked out about it. But the benefit of machine learning is using the data. So obviously no one wants a Facebook, Cambridge Analytica type scenario, but you look at how people have bought in with Amazon and all of a sudden I'm getting UPS packages every 5 seconds. So how do you think that we convince people of the good of all of the data being used together?
And I think that's where the personal identifiable information, when the data flows in, only specific people, that's where the governance and compliance and HIPAA, everything comes in. Those standards that I should not, it should be available only for the patient. And after that, once it moves into the bigger data analytics or the machine learning, we need to drop off a lot of those signals which can identify a person. And once you are able to do that, then it becomes just any kind of data, and then you are able to run your massive machine learning models. And we do need this data, because the more data we have, the better analysis we are able to do, the better models we are able to write.
I'd like to add another comment in there too, is with that data comes a better personalized experience. So that's where, years ago when we started seeing this from just a pure consumer marketing standpoint, consumers, we started to become more and more comfortable with, okay, I'm willing to share my data if that means I'm going to get more targeted ads and more specific experience based off of my information. It's actually relevant. I don't mind so much anymore when I start seeing ads for things that I was researching, because it's very targeted and it's actually helpful. So now apply that model and that concept and that thinking to healthcare, and think about more of a person, now we start moving towards personalized healthcare, and now adding in genomics and other very specific data, we can truly start to think about personalized healthcare then. So it's not just about the experience, it's really about the care delivery. The more data that you have on that specific person, the general data and the broader is helpful, but then you can get more and more specific down to that specific person.
I was going to add to Lisa's and Shika's perspective, not an entrepreneurial, but a patient perspective. I'm a patient advocate, and I like to say everyone is a patient, mm-hmm. Doctors are patients as well. So I think that, Carl, you raised a huge issue. So during this pandemic, I've gotten a lot of questions from very intelligent people, and they had to do with a lot of conspiracy theories. So I think that comes back to education. Sometimes when you talk about AI and ML, a person that's an outsider to a technology space might be confused. That's when you get into, maybe you should drink a lot of, like you have advice from your great grandma that says you should drink a bottle of vodka, maybe from Russia, right? No, not a good treatment for COVID. But patients come in and they ask, they're like, well, I've heard this information, or I've Googled this information. A next door neighbor mentioned something that if you do a trial for a COVID vaccine, you're going to be implanted with a tracker. And so first you just laugh, but then the second you realize that as an entrepreneur at that point, as a healthcare entrepreneur, that those are some valid questions. So I think, again, you just raised a number of complex issues within one question, Carl. I think consumer demands and requires proper education. Proper education has to go with, you can't just develop a vaccine in 2 months. That doesn't work that way. There are a number of reasons, including having proper data points. There are some regulatory reasons and so on and so forth, right? But I think you need to explain this to patients. And also, I think we need to have a proper regulation as far as data privacy is concerned and patients are concerned. I think patients' questions and these conspiracy theories, they highlight the need for again, regulation and education. And I think this is something that we have to address when we go into, telling a patient, please trust me with your data from an Apple Watch. I promise you, I mean no harm. And, oh, by the way, let's say you live with there's some, with a cardiac disease, and I want to also have you wear this particular monitor, and I want to transmit your data 24/7. So I think before you ask all of these questions, I think you need to team up with the care provider, and you need to explain to the patient, what are some of the risks, how those can be, or hopefully are addressed already. And so you can't just come in with the perspective, do so because I tell you so. I think you need to come in with the more of a compassionate approach.
Mhm.
I'd say one more thing, I think, just around, the whole notion of patients and their adoption and their willingness to engage and own and be accountable for the data. Back to the notion of the increasing importance, particularly in America, but I think some of you, like Sasha, might have a perspective on that overseas, as the home as a site of service across the whole care continuum, prevention and wellness, chronic care management, which we're heavily talking about right now, and population health. Acute, I think acute is somewhat less discussed, but truly some of the very largest and most celebrated academic medical centers are engaging in home hospital pilots right now, frequently with the payer for disease conditions like oncology or even congestive heart failure or others, but where patients might want to be treated at home. And so again, remote patient monitoring is a big piece of that. So that's acute. Then there's post-acute, where ambulatory surgery centers are becoming the norm. But again, the onus of the post-acute care at home and the monitoring of that patient becomes part of the patient and the family caregiver's responsibility. And then finally, home hospice. So I think, there's this whole notion of aging in place and the home as a site of service. It's kind of a thematic story. And if patients and members want that to be part of their experience and have the convenience of not being in an institutional setting, then they have to own the data. And COVID has certainly been a catalyst to that. So there are so many constituents. I don't think it's either or. I don't think it is the payer or the patient or the provider. They all play a role. Big tech is certainly being part of the catalyst. And then employers, to the extent that the very largest employers bear the cost of healthcare themselves, but then the fully insured smaller employers are putting that burden onto the health plans that are propelling them. So it's everybody, and then it's the government, through policy changes which they're doing. But the time seems to be now to make this happen.
So there are a couple questions in the Q&A section I do want to get to, because they are really pertinent, and one of them is around the process for providers. Providers are very overwhelmed with all the things that are going on within the EHR, and I always like to think of AI as assistive intelligence, helping to reduce the work there. How do we go about incorporating all of that technology, the RPM, into the existing processes, and also working with the EHRs that they are a part of? How do we go about making that a little more seamless? It's an open question. No one has to answer it all at once. So, Lisa, I'll let you take that one.
Yeah, just some ideas around this, because we're actually playing with a couple of pilots of the best way to handle that, right? So instead of just placing a device in the provider's practice for them to use or to send home with the patient, or that more traditional model that's managed under the provider, creating more of a and these models aren't new, but more of that genius bar type of a approach, where you can send them somewhere else for placement and education. And, and I think Sasha kind of referred to this too, around the healthcare literacy. And so that general overall education, and not just the device itself, but maybe of some of these pieces. So we've actually looked at a couple of different models for either helping the providers by placing someone in the practice to help them, or are creating an external model where they can send patients directly to us, and then we're sending the information back to the providers. So I think being open to looking at a couple of different ways and different approaches is really going to be welcomed right now. I don't think anybody has the exact answer. We're all starting from in some ways we're all starting back at square one, not completely square one, but we're in a new world that we can look at some of these different approaches.
If you don't mind, Carl, I'd like to add my perspective as well. So I've always said it's not about big data, it's about small actionable data. You hear time and time again when you develop a new solution, providers say, you know what we're doing has been working just fine, and to tell you the truth, we are overwhelmed with the to-do list. And you come in as an innovator, you want to say, but I have this better idea, but the reality is they are right. So my take on that, and that's not, just kind of independently formed in my head. Several years ago, I took a grad level course from Stanford School of Medicine on how to develop patient engagement software. And they taught us about neuroscience and behavioral economics. So just kind of tie that knowledge. So I think big data and AI models, and they will mean different things to different stakeholders. I think the goal when it comes to technology to deliver actionable value to the stakeholder that at any given moment is interacting with your software. So if you're collecting data, let's say on patient outcomes, that could be, the way you visualize it to a data science department in the hospital is entirely different than you would visualize it to a physician that has a patient in front of them. So for physician, they have, about 10 minutes to make a quick decision. They don't need to have a lot of information. They need to know within this visit and the patient's condition, maybe some of the events that took place outside of the hospital setting. What can I do now? What do I need to tell my patients now, right? What right kind of care model do I need to select now? And it needs to be available at the snip of the fingers. Now, in the data science department at the hospital, they need to have a lot more data points, a lot more holistic of a view with an ability to drill down, so on and so forth. So again, the way we're addressing that at PX Pulse, we're making data actionable. So we actually create, based on the data feeds, a specific task that we assign to a care provider and to a patient. So then AI and ML becomes something tangible. It becomes a specific item within a to-do list that both provider and patient can realistically get done.
So there are a couple questions up there from Mark King, who I happen to know. And he raises one of the interesting points of this that always gets asked. Whose data is it? When you start to talk about this, because legally it's actually the healthcare system, but you get into it and there's a very personal attachment to everything about you. And that comes back to, I know that we've talked about legislation. Anna, you talked about legislation and this and all the hurdles, but there's a ton of, when I bring something new to market and it has all the little flutter of the EKG on there, what does that really mean? What is this? How do I go through all the trials? How do I navigate these things? So it seems to me that there's a kind of a bigger discussion and fight that has to come in order to get these things to where I think we're all talking about envisioning them being the better outcome for the patient. Anna, do you have any thoughts around that?
As far as the data?
The data and the legislation around actually making this more about the patient themselves.
Yeah.
And allowing them to have trust that this has passed the right.
I mean, eventually that's what the holy grail is. I think there are a lot of entrenched interests here, right? And I think that's been one of the reasons that we haven't had the portability of the data for the member as they navigate from, navigate life stages and also navigate from perhaps, switching from one private payer to the other. There have been efforts to create, shared models and then transfer ownership through policy. I'm not sure that you can mandate that entirely. From the big tech perspective, I think Apple has taken probably, it feels to me like the greatest steps in moving this forward. They've been negotiating arrangements with several health systems so that, and I was surprised on, I can actually access my own, some of my own records from health systems that I've been part of through the Apple, the iPhone. And I think many of us don't even know what's available to us. But again, just to put a finer point on it, I'm not sure that it'll be policy driven. It'll probably be through disruptive technology that this happens. And that's how you kind of free that data from being owned at this point, if you will, by the payers who, see that as their asset.
That's a good call. Let me go through the poll questions real quick, and then we'll allow each of you to kind of give us a where do you think the future is. So one of the first questions was, what is the biggest barrier for remote patient monitoring adoption? It was consumers, providers, technology is not there. The number one answer was the payers. People believe that that'll be the biggest barrier is who's going to pay for this. The second one was, where will the big technology breakthrough come from? Small innovator over the big tech or the healthcare industry. Nobody voted for government or foreign entities, so I'm surprised by that. Are you currently implementing an RPM solution? Almost overwhelmingly not yet. So would you be willing to use it yourself? I thought this would actually be, it was almost 100% yes, they would be willing to do that. That's one of the ones where for me, I would have to see that this actually had passed certain things and it was meaningful for action. And that's where, for me, I would like to see a lot more meaningful numbers in there, as opposed to kind of, I would say, some of it being circumstantial at this point, from the tying it out. So let's go ahead and, do we have any other, let me check the last questions. All right, so this is the question is, what's the look ahead? And that's where I wanted to get to each one of you and go, what do you think the future looks like with actually taking remote patient monitoring and really incorporating it into that next 5 years of the future of healthcare? So Anna, let me start with you.
So I really think this is the, it's amazing with COVID particularly, it's the golden age of digital health. And it's, I think of it as a silver lining on this COVID cloud. We still have some reimbursement barriers to adoption, but we're increasingly getting alignment across the various stakeholders to move the needle around that. I think, at least for a period of time, providers asked for an equity across telemedicine, virtual health, and inpatient physical visits, and I think that'll become permanent and a reality. We'll move increasingly more to value-based care models. So, and then, the driver of the home is a site of service. The technology aspects of it, I think, my co-panelists are clearly better placed to answer that, but to the extent that we can drive interoperability across claims, clinical and remote patient monitoring data, enable it with, with predictive data analytics, AI and machine learning. I literally, 14 years ago at Aetna, we were doing little studies with remote patient monitoring and trying to combine claims data with clinical data. And it felt like the holy grail that we'd never get to. We've come a long way. And I think, the curve for adoption is moving pretty quickly.
And I'll just build off of that, right? So couldn't agree more that those value-based models will continue, that payer-provider collaboration will be key to this, so that I would add in patient to that, because that's that sharing of data too, that data that we may not be collecting currently. So all of those sources. From a technology perspective, I'll just throw one other maybe kind of thought and what the future, or maybe an area that we need to continue to think about, is that not everybody has access to technology still, even though we think it is we certainly ripped the Band-Aid off of things with COVID, right? So we know that technology is a solution and it works, but we still have rural areas that don't have access. And so maybe that's a combined model. So I would just kind of throw that out there, something that we need to continue to innovate around and think around how we can continue to access those areas. I think the pace will continue to accelerate at a much greater pace than it has over the last couple of years, and looking forward to being a part of that.
Shika, your thoughts on the future?
I agree with both Anna and Lisa. Absolutely. We're going to see more and more innovation. And of course, data will become the central part of it to be able to provide more personalized, actionable insights back to the patients, back to the providers and the payers. It's all going to be about how am I able to provide better care to my patients with the help of the data, with all the sensors. Now, in terms of do I really need to have the Wi-Fi, or can I have my physical devices which can directly transmit the data as an edge devices and all those kind of things. So I see technology is definitely going to be helping out in this.
Sasha, since you're furthest ahead in the day of all of us, I'll give you kind of the last one to show us the future.
I of course agree with the fellow speakers. Earlier, answering the questions, I've just kind of conversationally highlighted a number of issues that came into the surface. And I hope it's not wishful thinking, but or maybe it's me being an entrepreneur and being positive. I really hope that proper funding will be allocated to a healthcare space. I really hope that healthcare players can come together and agree on the data standards and implement it, and some other regulation will finally be written and approved by everyone in Congress. And I really hope that COVID highlighted the need for patients and providers collaboration. And I really hope that we are going to continue with that collaboration, because I really believe that without buy-in of the patient, the outcomes will suffer and the cost of care will continue to rise. And I really believe also that there is no substitute for professional caregivers' advice. No Google, no next door neighbor can give you as educated of an opinion as your family physician can. So I think technology will follow. I think people like myself and others on the panel will continue innovate and create tools that are user-friendly and easy, whether it is you are 70 years old or 10 years old.
Thank you all. You've been fantastic. And I hope you keep pushing the envelope and keep moving on, especially with how all of the data can be used to help us, and also making sure that providers have an edge when it comes to providing excellent, remarkable care. So thank you. Bojana, back to you.
Yes, thank you so much. I would like to thank all of you on behalf of the Analytics and Big Data Society for taking part in the panel and for such an insightful discussion. We were honored to have you as a guest.